Hello, this is Dr. Madhurima Ganguly, your Pediatrics faculty at Global Academy of Medical Education, and today we are going to discuss the recent Fmge July Pediatrics questions. So there were total of 18 questions in this session of Fmge. Among them, many were overlap questions between pediatrics, medicine, PSM, and biochemistry. So we are going to discuss all of them. I hope all of you have given a very good exam because most of the questions are either often discussed in your regular classes or they are often repeated questions. So we are going to discuss each and every question, and also we are going to also revise some other MCQs and one-liners which can be asked in your future exams, be it INICET or NEET or NEXT or the Fmge in the next session. Okay, so let us start. A child presents with vomiting and bilateral reversible oil drop cataract. So very important keyword, bilateral reversible oil drop cataract. I have revised this keyword in the marathon series as well. Oil drop cataract, whenever you see in your paper, there is only one diagnosis that should come to your mind, that is galactosemia. Urine had reducing substance positive but not glucose. Again, very important clue. That is non-glucose reducing substance positive in urine, and Benedict test is positive. So what is the diagnosis? It is very clear cut. It is nothing but galactosemia. So galactosemia is basically because of galactose 1-phosphate uridyl transferase enzyme defect. Hereditary fructose intolerance is because of deficiency in aldolase B, whereas essential fructosuria is because of fructokinase deficiency. So, since there was one question on galactosemia, let us actually revise what can be the other one-liners from galactosemia. Okay? The first thing is that what are the clinical features of galactosemia? So you can get in your question as failure to thrive, mild icterus, vomiting, and the most important clue, bilateral oil drop cataract. Galactosemia is an absolute contraindication of breastfeeding. We have only 3 contraindication, absolute contraindication of breastfeeding. One is galactosemia, number 2 is lactose intolerance, and number 3 is if the mother is on chemo and radiotherapeutic drugs. Okay, so galactosemia is an absolute contraindication to breastfeeding. And the children with galactosemia are more predisposed to E. coli sepsis. So more predisposed to E. coli sepsis. Okay, so they are more predisposed to E. coli sepsis. And other things that you should remember from here is that Christmas tree cataract is found in myotonic dystrophy, whereas sunflower cataract found in case of Wilson disease, and if we have a triad of cataract plus heart disease plus sensory neural hearing loss, it is congenital rubella syndrome. And remember, by heart disease, the most common one is patent ductus arteriosus, followed by pulmonary stenosis. Okay, so these are the one-liners that you should remember from galactosemia, and galactosemia is one of the important causes of liver cell failure as well. Galactosemia, tyrosinemia, all these are causes of liver cell failure. Okay. Next question, very good question. A child with celiac disease should avoid all except. Now we all know celiac disease is what? It is a gluten sensitive enteropathy. So what is it? It is a gluten sensitive enteropathy. So it is a condition where there is damage to the intestinal mucosa, and it occurs only in those individuals who has a genetic basis and also who are exposed to gluten. So gluten is found in which diet? In which food contains diet? Okay, so we usually have the mnemonic that is brow. B-R-O-W. B stands for barley. R stands for rye. O is oats. W is wheat. So all these four items are not given in a child or a patient with celiac disease. What happens? All these things contains gluten, and the specific component of gluten which causes the disease is known as gliadin. What happens? This gliadin which is present in the gluten, it mounts a cellular immune response, that is a T helper 1 response, and it stimulates some interleukins and interferons like interferon gamma, interleukin 15, interleukin 21, and also some NK cell mediated pathway. So at least for your exams, you should remember these items, barley, rye, oats and wheat, should be avoided in the diet, rather contraindicated, because the mainstay of treatment of celiac disease is gluten-free diet. So what component is present in all these food items? The answer is gliadin, and gliadin causes what? It's a T helper 1 response because it stimulates interferon gamma, interleukin 15. So if you have to mark one, you'll just say it's a cellular immune response and it is stimulating interferon gamma. So which HLA are responsible in case of celiac disease? HLA DQ2 and HLA DQ8. If we need to be specific, it is HLA DQ 2.5 and 2.2. But for your exams, please remember it is DQ2 and 8, 28 are responsible in case of celiac disease. So you're asked in the question, a child with celiac disease should avoid all except. That means a child can eat which item? So wheat, of course, it is contraindicated. Oats again should be avoided. And see, rice I haven't mentioned, so it can be possible. And the last option, what is it? It is also a component of wheat only, so it should be avoided also. Right? So wheat, oats and suji, all these things should be avoided. So what can be advised to the child? Yes, you can go for rice. So this will be the answer. Remember, oats should be avoided. It is not contraindicated in a child with celiac disease. But usually if you are taking oats in the pure form, you can take it. But specifically it should be avoided. So for your exams, remember this brow thing should be avoided in a child with celiac disease. And there are some hidden glutens as well. Like whenever a child comes to us in the OPD, we advise don't take candies, don't take any herbal medications, don't take any nutritional supplementation, and also some gravy, beer, soya sauce. All these things are avoided because this we consider as hidden glutens. Hidden glutens. Okay, so a next potential MCQ can be on hidden glutens. So hidden glutens in a child can be found in mainly candy, herbal medications, soya sauce, etc. Okay. Now, we would also like to know some MCQs related to celiac disease. First is most common immunodeficiency associated with celiac disease. The answer will be selective IgA deficiency. Next, remember, celiac disease predisposes to GIT lymphomas, and they are non-Hodgkin lymphomas. In celiac disease, you can get various types of clinical features. Almost my teacher in MD used to tell me that a child with celiac disease visits every specialty before coming to a pediatrician. Okay, so celiac disease will have, remember, it's anemia. So a child with short stature, anemia and GIT problems, we will consider celiac disease as a differential. So it is anemia. Okay. Skin manifestation that you are going to get in celiac disease is known as dermatitis herpetiformis. Okay. And type 1 diabetes mellitus is associated with celiac disease. So screening for celiac disease in a child with type 1 diabetes mellitus. I think I already told you repeated times, always in type 2 diabetes mellitus, we always do the screening things as soon as the disease is diagnosed. Like albuminuria, microscopic albuminuria, hematuria, ocular screening, all these things in type 2 diabetes mellitus, usually it is done at the time of diagnosis. But in type 1 diabetes mellitus, ocular screening or screening for kidney disorders like albuminuria and all, we do it after 5 years. So in celiac disease, screening is done after 2 years. After 2 years, we do the celiac screening in case of type 1 diabetes mellitus. What is the screening modality in case of celiac disease? So screening investigation of choice is anti-tissue transglutaminase, and it is IgA type. So IgA anti-TTG. So IgA anti-TTG is the screening modality of choice in case of celiac disease. If you are given in the question anti-TTGA plus total IgA, it will be a better answer, right? And what is the confirmatory investigation, or it is the investigation of choice or confirmatory? The answer will be biopsy. And the grading that we have in celiac disease is known as Marsh-Oberhofer grading. You can remember in short as the Marsh grading. Okay. Marsh grading. And what we expect, either we can expect intraepithelial, increase in intraepithelial lymphocytes, crypt hyperplasia, and villus hypertrophy. Atrophy. Villus atrophy. Crypt hyperplasia, villus atrophy, and increase in the intraepithelial lymphocytes. So this is type 1 Marsh, type 2, and this is type 3. Type 0 is normal mucosa. Type 1 is when there is increase in the lymphocytes, more than 40 per high-power field. Type 2 is hyperplasia of the crypts of labor cone. Type 3 is villus atrophy. Again, we can divide type 3 into A, B and C depending on how much atrophy of the villi has taken place. Partial, subtotal or total. And type 4 is complete destruction of the architecture of the intestine, right? And remember, previously we used to diagnose celiac disease only by biopsy. But nowadays we can do a serodiagnosis of celiac disease as well. So what do? We first advise for anti-TTG IgA and total IgA if it comes to be positive. Suppose anti-TTG IgA, if it is positive, that means if it is more than 10 times the upper normal limit, then we advise for a second antibody, that is anti-endomysial antibody. And if this is also positive, then we can say that celiac disease is confirmed. Okay. So almost I have told you almost all the MCQs that were asked previously. That is, nowadays celiac disease is a serodiagnosis. Screening is anti-tissue transglutaminase IgA. Confirmatory is biopsy. What are the biopsy findings that you get in a celiac disease? The name of the grading system is known as Marsh-Oberhofer grading system. Type 1 diabetes mellitus associated with celiac. Skin manifestation, plenty are there. Most important, dermatitis herpetiformis is there. And we have the GIT lymphomas over here, anemia here, and selective IgA deficiency. The presentation will be, it can be constipation, diarrhea, alternating bowel habits, abdominal pain, abdominal distension, anemia, short stature. There can be headache, there can be mouth ulcers, and also there can be ataxia, and other manifestations like autoimmune diseases can be associated with it. All these are findings that you can get in celiac disease. Okay. And it is quite prevalent in North India. Okay, now see this. An image was given about a hand, and I think you can appreciate that there is a single crease, okay, single palmar crease. This is known as the simian crease. In this hand, and you already know this is a very common thing, that this is nothing but trisomy 21, that is Down syndrome. Two questions were there in this year FMGE on Down syndrome. One was this image based question of trisomy 21 Down syndrome. Okay, so the answer will be 47XY plus 21. So few one-liners. Most common cardiac defect in Down syndrome. Cardiac association occurs in 25 to 50% of the cases. The answer will be endocardial cushion defect, sometimes also written as AV canal defect. In Down syndrome, you can get TOF, you can get ASD, VSD, etc. But the most common will be endocardial cushion defect. Most common GIT manifestation in Down will be duodenal atresia. If duodenal atresia is not given in the question, the next best will be Hirschsprung's disease. Most common malignancy, or I can put like this, hemat malignancy, hematological malignancy. In both ways the answer is same, that is ALL. Remember, AML M7 is most specific, but not the most common. Most common hematological manifestation is transient myeloproliferative disorder. Okay, not ALL, not AML M7. This is mostly the wrong answer that is given. Down babies also are predisposed to hypothyroidism, which occurs in 2 to 5% of the cases, and there is a chance of early Alzheimer's, disease, and hearing loss. And there was one question that was asked, that is, they can have atlantoaxial dislocation. So what percentage of Down babies can have atlantoaxial dislocation? The answer will be 1%. So 1% of Down baby can have atlantoaxial dislocation. Okay. Along with spinal cord compression, there can be hearing loss as well. So congenital heart diseases are very common in Down syndrome. But remember, ischemic heart diseases are not common in Down syndrome. It is more common in general population. Rather, this acts as a protective factor. Down's babies are not predisposed to ischemic heart diseases. So this is a catch over here. Remember, Down babies are predisposed to everything, but they are not predisposed to ischemic heart diseases. Ischemic heart diseases are more common in general population as compared to Down syndrome. This is a direct line that is given in Nelson. Now again, this is an image based question. It's regarding the neural tube defects. Birth defect in the following image, you can see there is partially there is absence of cranial vault, and there is a contiguous defect of the spine as well. So the best answer here is anencephaly with craniorachis. Okay, so this is nothing but a neural tube defect. So anencephaly is absence of cranial vault, whereas rachis is basically extension into the spine. It can be anywhere. It can involve the entire spine, or it can involve up to the cervical spine, from the cervical spine up to the sacrum, etc. So regarding neural tube defects, just remember neural plate, neural groove, neural tube. So first there is a neural plate, and then there is a groove, and from there forms a tube. Okay, this is the embryological development of the neural tube. Next we have, since there is a tube formation, there is an anterior neuropore and there is a posterior neuropore. So anterior neuropore and posterior neuropore. Just remember, start from 18. So this is 18 days of gestation. Neural plate forms at 18 days of gestation. Then the groove forms at the 20 days of gestation. Next, neural tube formation at 22 days. Anterior neuropore closes by 24 days and posterior neuropore closes by 26 days. When the anterior neuropore fails to close, we have got neural tube defects. Again, when the posterior neuropore fails to close, we have other neural tube defects. Like if the posterior neuropore fails to close, we can have other defects like spina bifida, meningocele, myelomeningocele, where there is a protrusion. In what happens in myelomeningocele, there is a protrusion of the CNS parts like the meninges. Even brain also can herniate down. In anterior neuropore, there is absence of formation of the cranial vault if it fails to close. So you need to remember this days of gestation. If there is a prior neural tube defect, then we must start folic acid preconceptionally. Before pregnancy is diagnosed, we need to start with folic acid. So which can prevent neural tube defect? The answer is folic acid. So we need to give 0.4, it is 4 milligrams of folic acid if there is a prior neural tube defect. Suppose there was a previous sibling who has got a neural tube defect, or if the mother is having an over diabetes mellitus, or if the mother is on some teratogenic drugs like valproate, so we need to give 4 milligrams folic acid. Otherwise, the prophylactic dose is in no risk factor. The answer will be 0.4 milligrams folic acid. So in other cases, going to give as a routine 0.4 milligram folic acid. In the high risk cases, we are going to give 4 milligram of folic acid. So what are the risk factors? Some anti-epileptics like valproate and carbamazepine, among them valproate you should remember. Folic acid deficiency and zinc deficiency. Remember, hyperthermia is a cause. And there are other also like chromosomal defects, etc. Some teratogenic drug usage which can cause neural tube defects. And the only thing that can prevent is folic acid. If there is no risk factor, there is a chance of 4%. If there is one risk factor, the chance is 10%. Two or more, the chance is 25%. So we need to prevent this neural tube defects, and the only thing that is possible is by giving folic acid, and we should start it preconceptionally. So remember this, folic acid should be started preconceptionally. And what are the biomarkers to test for neural tube defects? So biomarkers for neural tube defects, one is acetylcholinesterase. This is the best answer possible. If this is not given in your option, the next will be alpha fetoprotein. Alpha fetoprotein is, you see this marker at various places, like in hepatocellular carcinoma, also in ataxia telangiectasia. The third thing you remember is neural tube defect. So acetylcholinesterase and alpha fetoprotein are the biomarkers to test for neural tube defects. Okay. Child presents with bilious vomiting, image is suggestive of. So first of all, before looking at the image, let us look at the option. The first option is CHPS, right? Congenital hypertrophic pyloric stenosis. It cannot be the option because the presentation will be non-bilious vomiting. And we already know that any neonate who presents with gross bloody stool, bilious vomiting, in the first 24 hours of a life should always be considered as a surgical neonate. And whenever we are thinking about a surgical neonate or surgical abdomen, the first investigation that we go is an X-ray AP view of the abdomen, right? So we advise an X-ray, and this is the X-ray picture. Can you see that this is the stomach and this is the duodenum? So there are two bubbles. So it is nothing but double bubble sign, and double bubble sign, one diagnosis that fits in the option, that is duodenal atresia. So this is the double bubble sign. What happens is that if there is an obstruction, like if there is an obstruction, for example, in the pyloric stenosis. So since there is an obstruction at the pylorus, nothing can go beyond it. So in X-ray, we'll get a single bubble. But what happens in duodenum, the obstruction is up till beyond the duodenum. So we get two bubbles, double bubble. What happens in jejunal atresia? We get triple bubble sign. In ileal atresia, we'll get multiple bubble sign. Okay, it depends on the location of the obstruction, we get the bubbles. And remember, jejunal-ileal atresia is more common than duodenal atresia, right? So jejunal-ileal atresia, not jejunal. I am telling jejunal plus ileum as a whole. Jejunal-ileal atresia is more common than duodenal atresia. So in jejunal atresia, we are going to get the triple bubble sign. And as I told you, in ileal atresia, we are going to get the multiple bubble sign. And the classic here, this is the double bubble sign. That is suggestive of duodenal atresia. So can you tell me some differential diagnosis of double bubble sign? Okay, apart from duodenal atresia. So differential diagnosis of double bubble sign will include duodenal atresia, annular pancreas, because pancreas is located in the C shape of the duodenum. Okay, so annular pancreas, duodenal stenosis, vascular compression. Right? So, two or three things more regarding duodenal atresia. As I told you, duodenal atresia 50% is associated with prematurity and 50% is associated with chromosomal abnormalities. And the most common association being the Down syndrome. Right? So most common association in case of duodenal atresia being the Down syndrome. And remember the presentation on day 1 of life. The neonate is going to present with profuse bilious vomiting and abdominal distension. So then you'll think that, okay, this is a surgical abdomen, so we need to go for a minimum x-ray. And in the x-ray, when you see a double bubble, then you think that, okay, this is a case of duodenal atresia. And the treatment is duodenostomy. Duodenostomy is the treatment of choice in case of duodenal atresia. Right? So there are again various 3 types of duodenal atresia, type 1 being the most common form of duodenal atresia. Wernicke's encephalopathy is due to deficiency of, this is, you all know, this is thiamine. Okay, that is vitamin B1. And again, Wernicke's encephalopathy, it's a triad of global confusion, you get ophthalmoplegia, even nystagmus, and ataxia. So we commonly remember the mnemonic as Goa. And usually you get a classic history of a chronic alcoholic in an adult patient comes with the symptoms of confusion, ataxic gait, along with ophthalmoplegia. What is the diagnosis? The answer is Wernicke's encephalopathy. It can occur due to deficiency of vitamin B1. Another thing that I would like to say is, what is the cause of death in beriberi? The answer will be cardiac. Okay, so cause of death in beriberi, and the answer is cardiac. What is the dose of vitamin A in a child between 1 to 8 years of age? The best option answer to this question is 2 lakh international unit every 6 months till 5 years. So I think you all know this regarding vitamin A. Let me tell you. In case of treatment, less than 6 months, 6 months to 12 months, and more than 12 months. So we give 50,000 international units. Here it is 1 lakh. It is 2 lakh international unit. And the dosage is like this. We give, according to WHO, we give on the day of diagnosis, on the next day, and we repeat 2 weeks later. And what about the prophylaxis? Below 9 months, it's 1 lakh units, international units. Above 9 months, it is 2 lakh international units. Every 6 months till 5 years of age. But this is beyond 9 months. Okay. And remember this thing also, that what is the earliest sign of vitamin A deficiency? The answer will be delayed dark adaptation. And we already know about the grading, like X1 was conjunctival xerosis, X2 was Bitot spots, X1A was, X1A was conjunctival xerosis, X1B was Bitot spots, okay? And the later on, there will be corneal xerosis and keratomalacia. So initially we are going to get conjunctival xerosis, later on we are going to get the corneal xerosis and keratomalacia. So at least you should remember these things. And vitamin A is given in case of, is given in measles outbreak. Measles outbreak. Remember, always in measles outbreak or in measles we give vitamin A supplementation, because in measles we get vitamin A deficiency. So again, this is a very repeated MCQ and one-liner. How many ml per kg of milk should be given in the first 24 hours after delivery in a term baby? Just note the keywords. I already advised you to read and reread the question before attempting all the answers. It is a term baby, first 24 hours after delivery, ml per kg of milk. Since it is a term baby, the answer will be 60 ml per kg. If it is a preterm, the answer would have been 80 ml per kg. And if it is an extreme preterm, then it is 100 ml per kg. And you are asked in day 1. From day 2 we add plus 15. So day 2 of life in a term baby, we are going to get 75 ml per kg of fluid. Okay. And in the first 2 days in a neonate, we always give 5D. From the day 3 onwards, we can give other fluids. Sorry, we give 10D. We give only dextrose. In case of extreme preterm, in the first 2 days, we give 5D. But in rest, in the first 2 days, we usually give 10D. From the 3rd day onwards, we can give any fluid. We can also give electrolyte fluids along with electrolytes like isolite P and etc. Right? Usually in the first 2 days in newborn, we do not give fluid that contains additional electrolytes. Understood? So how many ml per kg? The answer will be 60 ml per kg of milk should be given in day 1 in case of a term baby. If it is a preterm, the answer would have been 80 ml per kg. If it is day 2 in a term baby, the answer would have been 75 ml per kg. If you're asked the choice of fluid in an extreme preterm, the answer would have been in the first 2 days 5D. In the rest, the answer would have been 10D. Okay. Criteria of MUSC in severe acute malnutrition. Now, I already tell you that in every exam, protein energy malnutrition is a very, very important topic. And the examiners, it is a sort of examiner's favorite, be it any exam, right? Coming from NEET PG to any other exams. So severe acute malnutrition, mid-upper arm circumference. Some of my students told me in my Telegram group and mailed me also like that the answer was the question was criteria of MUSC in Shakir's tape in severe acute malnutrition. So I have got a doubt regarding this question, that whether the question was regarding only SAM or it was the MUSC criteria in severe malnutrition in Shakir's tape. But please be assured, whether it is a Shakir's tape or simple severe acute malnutrition, the answer is only one. Okay, that is less than 11.5 centimeter will be the answer of MUSC in severe acute malnutrition. Okay, so let us see the criteria. If any one of the following is present, then we call it as severe acute malnutrition. So what is the criteria? The first is severe wasting. So please understand the definition of wasting. It is weight for height less than -3 Z score. So weight for height should be less than minus 3 Z score. Mean upper arm circumference is less than 11.5 centimeter. This is asked in your paper. And bilateral symmetrical edema of nutritional origin. If any one of them is positive, we call it severe acute malnutrition. Okay. And what is wasting? It is weight for height. Very, very important. Weight for height is termed as wasting. Now, this is a picture that is used usually this is an instrument usually used in the field workers. This was asked in NEET PG 2021. Okay, regarding this, that is the Shakir tape. This is called as Shakir tape. Can you see the 3 zones over here? This is the red zone. Okay, this is suggestive of severe acute malnutrition. This is the green zone. That means there is no nutrition, and this is the yellow zone, which is borderline. So if the Shakir step is showing you less than 11.5 centimeter, that means we are having, see, 11.5. This is the cutoff over here. So that means it is MUSC less than 11.5 is SAM. 11.5 to 12.5 is the yellow zone. If it is more than 12.5, it is green zone. So one-liners once more. Shakir tape used in field. So it can be used by any person like Anganwadi workers, A&M, etc. to interpret what? Malnutrition. What is the modality to interpret malnutrition by means of Shakir tape? The answer will be mid upper arm circumference. What is the criteria of severe acute malnutrition in case of Shakir tape? The answer will be less than 11.5. So what zones are there in Shakir tape? We have green, red and yellow zone. Red is danger. Red, that is severe acute malnutrition. Green is good, no nutrition, no malnutrition. Whereas yellow is borderline, 11.5 to 12.5. So this is the new WHO grading in case of Shakir tape. So you need to remember this and this image for your future exams. A child presented with recurrent infection, height for age is less than expected. Parents had incorrect feeding method, appropriate term for this condition. Only one keyword here is important, that is height for age. So I already told you wasting means weight for height less than minus 3 SD. So what? So height will be, the answer will be stunting. So stunting is a marker of, remember, chronic protein energy malnutrition. If wasting is there, it is a marker of acute protein energy malnutrition. If there is both wasting and stunting, we call it as acute on chronic PEM, right? Kwashiorkor is a type of severe acute malnutrition where we'll have edema, mental changes, etc. And so it is not stunting and wasting because it is mentioned height for age. And of course, if the child is malnourished, there is going to be various complications. There can be hypoglycemia, increased chance of having infections, electrolyte deficiency, diarrhea, death, micronutrient deficiency. So we remember it by the mnemonic shielded. A stands for sugar deficiency or hypoglycemia. The cutoff in PEM is 54. Remember, it is 54, not 45. It is 54. H stands for hypothermia. I stands for infection. EL stands for electrolyte deficiency. Not deficiency, abnormalities. The most common electrolyte abnormality in SAM is hypokalemia. What? It is hypokalemia. D for diarrhea. And the last E for nutrient deficit, that is the micronutrient deficiency, and the last D is death. Okay, so this is the complication that you can get in case of protein energy malnutrition. that can be remembered by this mnemonic shielded. Hypoglycemia, hypothermia, infection, electrolyte deficiencies, diarrhea, death, and micronutrient deficiency. Among them, the most common electrolyte deficiency being hypokalemia, and the blood sugar cutoff in case of SAM is 54 milligrams per DL. Third question on malnutrition. A child presents with malnutrition, severe dehydration, choice of IV fluid in this condition. The answer will be RL plus 5D. Now let me tell you, any SAM child coming to you with dehydration, we take it into consideration that there is some dehydration. Okay, you need to remember, any SAM child presenting with diarrhea, we consider as some dehydration is present. So we start with ORS or a solution that is known as Resomal. Rehydration solution in malnutrition. So what is the full form of Resomal? Rehydration solution in malnutrition. Okay. Now, if it is a SAM child and if the SAM child is coming to me with dehydration, so SAM plus severe dehydration, there is no role of oral fluids. We need to start with IV fluids. The best IV fluid of choice is RL plus 5D. If it is not given in your option, the next best is RL and the next best is N by 2 plus 5D. Remember, dextrose is never given alone. So what is the order of IV fluids? It is RL plus 5D, or it is RL, or it is N by 2 plus 5D. Usually we give 15 ml per kg over 1 hour. We reassess the child, and then if the child again is having dehydration, we repeat it 15 ml per kg of IV fluid, and if the child responds, then we shift to maintenance fluid, and if the child responds further to maintenance fluid, we shift to ORS and NG tube feeding once the child can accept feeds. But if the child do not respond, even after resuscitation with IV fluids, we treat it as a form of septic shock. Okay, so what you need to remember from here is that we never give dextrose alone in SAM with severe dehydration. So the answer will be, best answer will be RL plus 5D. If it is not given in your option, the next best will be RL. And if it is not given in the option, the answer will be N by 2 plus 5D. So let us go back to the question. So it's a malnutrition and severe dehydration. So there is no role of oral fluids. You need to give IV fluids, parenteral, right? So what IV fluid can you give? Okay, here, so ORS you cannot give. Again, I said you cannot give dextrose alone. So this cannot be. So it is not only shock. So we have to treat it like shock at the last stage, when it doesn't respond to normal IV fluids. So the best answer is RL plus 5D. If it is not given in the option, the next best will be RL or N by 2 plus 5D. So these are the alternatives which we can give in malnutrition with severe dehydration. But if it's a SAM with diarrhea, we'll consider it that the child is having some dehydration. We are going to start the child on ORS or Resomal, whichever is available at that time in the ward or the ER. Okay. So 3 questions on malnutrition. It becomes a very extremely important topic for your next Fmge exams and others. So you need to revise malnutrition before sitting for any exams. Okay. So this is the take home message. Now, quadruple test for Down syndrome. Again, a very repeated and a good question. Is done in which trimester? The answer will be second trimester. So you all know that quadruple test includes beta HCG, unconjugated estriol, alpha fetoprotein, and the other thing is, yes, alpha fetoprotein again in Down syndrome as well. I already talked about alpha fetoprotein being a marker of neural tube defect, alpha fetoprotein in hepatocellular carcinoma, in ataxia telangiectasia, alpha fetoprotein as a part of quadruple test in Down syndrome. And the last one is inhibin A. So remember, beta HCG increases, inhibin A increases in Down syndrome, unconjugated estriol and alpha fetoprotein decreases. So you can remember by the mnemonic high. That is HI, this 2 will increase in case of quadruple testing for Down syndrome. That is H for beta HCG and I for inhibin A. And another thing, what is the triple test for Down syndrome? Triple test is beta HCG, unconjugated H12 alpha fetoprotein. So if we are including inhibin A, then it becomes the quadruple test. If we are not including inhibin A, then it becomes the triple test. So it is done in second trimester. So quadruple test is a screening test or a diagnostic test? The answer it is a screening test. Right? So let me ask you, in the first trimester, what are the parameters that you test? Biochemical parameters. In USG, we all know that we test for the nuchal fold thickness. So what are the biochemical parameters? One is beta HCG, which increases, and the other is PAPA, pregnancy associated placental protein A. Okay, this decreases. So this is the first trimester markers that we go for this. What is the best investigation that you can do? You can just combine the first trimester biochemical and USG findings with the second trimester biochemical and USG findings and collaborate it. We call it as integrated test. So this is the first trimester screening test. Then you go for the second trimester screening test. You get doubly sure, because the first trimester with the biochemical markers and the USG findings, the sensitivity is 84%. When you do the second trimester USG and the biochemical markers, it is around 76%. Combines, it's around 90% sensitivity. There is another new screening test that is known as NIPT, non-invasive prenatal testing, which uses cell-free fetal DNA in maternal serum. So you just need the maternal blood for testing this, but again this is a screening test. The sensitivity is around more than 90%, rather we should say it is more than 95%, but it is a screening test. It is not a diagnostic test. If the screening tests are positive, then you need to go for the diagnostic tests, and we know the diagnostic tests are either we need to go for the chorionic villus sampling or the amniocentesis, chordosynthesis, etc. We do not do chordosynthesis, etc. because the risk of miscarriage is high. Amniocentesis is the most safe diagnostic test which we perform in the second trimester. Amniocentesis, if it is done in the second trimester, the loss rate is around 0.5 to 1%. Okay. So amniocentesis is done in the second trimester with a loss rate of 0.5 to 1%. So we prefer amniocentesis as a diagnostic test because genetic counseling is very, very important nowadays. So are you thorough with the screening modalities, the antenatal screening in case of Down syndrome? Very, very important topic. Identify the image. So see the forearm over here. This is more of an orthopedics question rather than a pediatrics. So the forearm is inclined away from the midline. Okay, so this is the body. So it is away from the body. So this is known as valgus. So if it is away or outward, that is valgus. If it is inward, that is varus. This is how I remember. Madelung deformity you will get in case of Turner syndrome. Calcaneovarus is something related to the foot, not with the hands. So varus and valgus deformity in any part of the body, you remember like this. Valgus means outward, varus means inward. Okay. Cubitus valgus is associated with two pediatric syndromes. Can you tell me what syndrome? Yes, it is associated with Turner syndrome and Noonan syndrome. Okay. So Turner syndrome and Noonan syndrome is associated with cubitus valgus, but you need to remember that fracture of lateral condyle of humerus, if it is non-unites, then it results in cubitus valgus deformity. So this is again a very important MCQ. So cubitus valgus deformity because of fracture lateral condyle of humerus. Okay. Again, much repeated question. A child presented with cough, coryza and conjunctivitis. 3 C's. Cough, coryza, conjunctivitis. And you know the diagnosis. And again, you are given another clue also. Rash initially started behind the ear. So it is nothing but it is measles. Okay. So this will be the answer to this question. The answer is measles. In measles, you get Koplik spots as well. So we are going to read some few one-liners which can be asked in your future exams regarding measles. But let me tell you one thing. In German measles, or what is known as rubella, you are going to get the Forsheimer spots in the palate. And we already told about the congenital rubella syndrome, the triad of congenital rubella syndrome, the most common heart defect being the patent ductus arteriosus, followed by pulmonary stenosis. What is the most common complication in case of mumps? Can you tell me? Yes, mumps presents with parotitis. What is the most common complication that we can get in mumps? Yes, in mumps we get aseptic meningitis. So in mumps the most common complication being aseptic meningitis. However, in adolescents we are going to get the oophoritis to be the most common complication. Aseptic meningitis. Parvovirus B19 will present with fetal anemia. Others you remember, there can be arthralgia. It is an important cause of non-hydrops fetalis, non-immune, hydrops fetalis. And you can remember about the slapped cheek appearance. Slapped cheek appearance that you can get in parvovirus B19. So in measles, the first question you can remember, the most common complication of measles is acute otitis media, and the complication of measles that results in death the answer will be pneumonia. Either what happens in case of measles, you can either have secondary bacterial pneumonia or a primary measles pneumonia. Okay. There can be meningitis encephalitis as a complication of measles as well. Vitamin A deficiency occurs in case of measles. That is why in all measles outbreak we have to supplement with vitamin A, and this is a must. Another thing that you can remember is the most late and fatal or lethal, whatever you say, complication of measles in children is SSPE. What is SSPE? Subacute sclerosing panencephalitis. From here you need to remember 2 or 3 things. Like in here you are going to get cognitive defect or dementia plus myoclonic jerks, chorioathetoid movements. So it is a fatal thing. Whatever you do, the child will pass away. We have the Dykens criteria for the diagnosis of SSP. The EEG will show the Rader-Macker complexes, very, very important thing. And the drug of choice for the seizures, that is the myoclonic jerks in SSP, is carbamazepine. Remember, carbamazepine is contraindicated in myoclonic jerks in children, but in myoclonic jerks associated with SSP, carbamazepine is the drug of choice. Why do we avoid carbamazepine? Because of various side effects, the most important being the electrolyte abnormalities of hyponatremia. That is why we do not prefer to give carbamazepine, and the EEG will be suggestive of Rader-Macker complexes. Okay. There are some stages. Usually in SSP grade 1, we are going to get the child will have behavioral abnormalities. In grade 2, there is going to be myoclonic jerks. Grade 3, there is going to be dystonias and chorioathetoid movements and cognitive decline. And the grade 4, the child will be in a vegetative state. We usually can give isoprenosin, etc., intrathecal interferon. But you just need to remember it's the most late and fatal complication. We can't do anything. The child will die. So if you get in your question cognitive defect, dementia and myoclonic jerks, the answer, and there is a prior history of measles in that child, the answer will be SSP. An HIV female not taking any antiretroviral drug, this is very important, not taking any antiretroviral drug delivered a baby, what should be the initial treatment? The answer will be a combination drug, nevirapine plus zidovudin for 6 weeks. Remember, in an HIV positive female, if she delivers a child and if the maternal viral load is very high, that is not suppressed, and it remains high beyond 32 weeks, if the mother is not on any antiretroviral therapy, HIV-1 and HIV-2 infection, then we usually give nevirapine plus zidovudin as a combination therapy for 6 weeks. 6 weeks, actually there is what is the recent guideline is that if you're going for exclusive replacement feeding, then we need to start nevirapine plus zidovudin from birth till 6 weeks. If it is an exclusive breastfeeding, then we need to continue it for 12 weeks. And if the maternal viral load is not high, the mother is on ARTs, then we can give as a monotherapy with nevirapine only. So syrup nevirapine is going to suffice. So in pediatric HIV, you need to remember this nevirapine and zidovudin therapy for 6 weeks, very important. And what we advise to the mother in case of pediatric HIV, we do not advise for mixed feeding. It is not contraindicated, but it should be avoided. We give options to the mother that either you need to go for exclusive replacement feeding or you need to go for exclusive breastfeeding. So remember, breastfeeding is not contraindicated in a child with HIV. Remember this. Okay. So nevirapine plus zidovudin for a period of 6 weeks will be the answer to this question, right? So if it is a replacement feed or formula feed, then it is up till 6 weeks. If it is a breastfeed, till 12 weeks. I don't know about the other options which were given, but the best answer is which I collected from my students is nevirapine and zidovudin for 6 weeks. Please comment in the comment box if you can remember the other options, and I'll modify accordingly, or mail me. Identify the image. So there were various options given. These are the nothing but the kidneys. Okay. And you can see the kidneys are fused. So you know this is nothing but the horseshoe kidney. So the first point that you should remember, it is the most common renal fusion anomaly. Left kidney crosses the midline and fuses with the right kidney. What happens, the kidney ascends during development. Very important. That is, kidney ascends during development. Normally in the embryogenesis, kidney ascends during development. So there is a problem with the ascent because the ascent of the kidneys is restricted by, in case of horseshoe kidney, by the inferior mesenteric artery. So who limits? The artery which limits the ascent in case of a horseshoe kidney is inferior mesenteric artery, right? And horseshoe kidney. So can you see the fusion? The lower poles of the kidney are mostly fused. So the best investigation that you can do is a CT scan. But apart from the CT scan, you need to also know about the IVP image. So this is an IVP image. Can you see the orientation of the kidney? Right? So this is the IVP image, and this is known as, like the flower vases, we have the flowers and they are fused, the lower poles of the flowers are fused. So this is known as the flower vase appearance, also known as handshake appearance. Handshake or joining hands, whatever you say, handshake appearance. But IVP is not the diagnosis or the investigation of choice in case of horseshoe kidney. Investigation of choice is definitely a CT scan. Remember, there is 8 times more risk of Wilms tumor in a child with horseshoe kidney. And the most common syndrome that is associated in a horseshoe kidney is the Turner syndrome. right? So we always teach you that the most common cardiac defect in a Turner syndrome is bicuspid aortic valve and coarctation of aorta, whereas in case of the renal anomaly in Turner syndrome is always horseshoe kidney. So you need to remember this, very very important, and it is a personal favorite of FMG. They either put the IVP image or the CT scan image or some one liners based on horseshoe kidney every time. So this is a repeated question. Now coming to pedigree, no exam is complete unless and until we have a pedigree. Okay, so here always remember for your any exams, since we are doing it as a practical exams now, after now it's an MCQ based exams. Whenever you will approach your residency and etc., whenever you need to draw pedigree, you should always see it by 3 generations, right? This is a dictum. Now see here a male is affected, and from here a male is affected. So male to male transmission is possible, that is a father is transmitting to his sons. So if a father is transmitting to his sons, it cannot be X linked, so it goes out. Why? Because the father can pass the X chromosome only to daughters, not to sons, so X linked goes out of the question. Now look at the 3 generations. This is generation 1, this is generation 2, this is generation 3. See, from 1 to 2, the generation is skipped. Here, none of them is affected. Again, this person marries a girl who is affected, and they have got one diseased male, right? So, skipping of generations is present. First of all, in this pedigree, you are seeing there is no there is presence of male to male transmission. Number 2, skipping of generations is present. If skipping of generations is present, it cannot be autosomal dominant. So the answer will be autosomal recessive, right? I'll explain all the pedigrees further in a separate YouTube video, and I've already taken this in my regular classes. But for a quick analysis of your pedigree, just remember, if you see in your paper male to male transmission is present, it cannot be X-linked. Then you see if there is skipping of generations present, it cannot be autosomal dominant, it is autosomal recessive. And see here both the male and the female is affected, all the offsprings are affected. So all the offsprings will be affected if both the parents are affected. Here a single parent is affected, a single offspring is affected. So for autosomal recessive, if both the parents are affected, all the offsprings will be affected. So that is why this is an autosomal recessive condition. Okay. And skipping of generation, you can see in the 2nd generation, there is skipping of generations like this 3. Now, infant in a nursery developed difficulty in breathing, symptoms improved on crying, diagnosis. I really don't know the exact question and I really don't know the options, but people texted me that this was somewhat the question was like this. So what I can make out, that there is a problem with breathing which improved on crying. So a congenital anomaly that is improving on crying. Okay, so the answer will be choanal atresia. So it is a congenital anomaly of nose. You know, the infants are obligatory nose breathers. Okay, they are not mouth breathers, they are obligatory nose breathers. What happens in choanal atresia is that usually there is a cyclical cyanosis. What is cyclical cyanosis? The cyanosis occurs at rest but improves on crying. It can be unilateral, it can be bilateral. If it is bilateral, it is severe and presence in the neonatal period. If it is unilateral, it will present in infancy. How do we diagnose? We can do an anterior rhinoscopy, but the investigation of choice will be CT scan. Now, it is associated with various syndromes, like you have the Chart syndrome, Treacher-Collins syndrome, tracheoesophageal fistula, or some disorders of craniosynostosis as well, Pfeiffer syndrome. This was much repeated regarding the association of Chart syndrome and coronal atresia, because in INICET many a times this question came, like a child presents with cyanosis at rest which improves on crying. It is this condition is associated with which syndrome? The answer will be Chart syndrome. So C for coloboma, mainly the retinal coloboma. H for heart defects. It can be anything from ASD, VSD, TOF, etc. A for atresia of the corona. R for growth retardation along with CNS retardation. G for genitourinary anomalies. And E for ear anomalies. It is a disease that is associated with CHD7, right? So this is the Chart syndrome. Now many a times we use the word syndrome and association and we are confused what is meant by syndrome, what is meant by association. Usually syndromes, they have got a recurrence risk, they have got developmental anomalies, and they have got a genetic basis. So syndromes are those conditions where we have got multiple anomalies combined together, they have got a genetic basis, developmental disabilities, and recurrence risk. But associations are, they are also multiple anomalies, but they do not have developmental defects, they do not have recurrence risk, they do not have a genetic basis. For example, Vactral association. Vactral is an association. We know Vactral is associated with what? Tracheoesophageal fistula. But Charge is a syndrome. So Charge is a syndrome, Vactral is an association. You need to remember this small concept, right? So this is the Charge syndrome. And so what treatment you are going to provide in a child with coronal atresia? Let us just revise that. So if it is unilateral, then you need to go for surgical intervention. If it is a bilateral thing, then you need to secure airway. Even you need to intubate also, right? Intubation and securing airway. That is stabilizing the child and then going for surgery in first 3 months. Right? So intubation and securing airway and surgery in the first 3 months. Okay. So that completes my FMG pediatric session. Please let me know in the comment section if there are further questions, because I did not get any other questions from as far as pediatrics point of view. I heard some questions are there, overlapping questions like drug of choice in facial nerve palsy. The answer will be prednisolone, like Bell's palsy, the lower motor neuron palsy. There was one question on Sjogren's syndrome with dry eyes and dry mouth, and there was one question on poor wound healing. Poor wound healing is basically because of two things. Remember, one is vitamin C deficiency and the other is zinc deficiency. Vitamin C because it helps in collagen synthesis because of prolyl and lysyl hydroxylase. Zinc because it helps in, it has a role in metalloproteinases. So these questions are overlap questions of biochemistry, pediatrics and else. There was one question on Anemia Mukt Bharat 6x6x6 strategy. That is also an overlap question of pediatrics and PSM. So these are the exclusive pediatric questions which I discussed. Please let me know if I have missed out any question in the comment box, and please let me know in my Telegram group and in my mail. Thank you.